Welcome to a brief lecture on the history and evolution of healthcare information systems. The objectives for this lecture are to describe the history and evolution of healthcare information systems, or HCIS for short, from the 1960s to the present. We'll identify some of the major advances in information technology, as well as some of the significant federal initiatives that influence the adoption of these healthcare information systems. Finally, we'll discuss the supporting roles of computers, the Internet, and the World Wide Web as they apply to healthcare. During this presentation, we will look back in time and briefly review what was happening with healthcare and information technology at various times in history since the 1960s. Additionally, we'll also look at some of the federal initiatives and legislation and see how general-purpose information systems evolved into what is now the current state-of-the-art in healthcare information systems today. We'll start in the 1960s. The Medicare and Medicaid programs were signed into law in 1965 by then-President Lyndon B. Johnson. Cost-based reimbursements were also introduced during this time period. This meant that the payer, whether it was a private insurance company or the federally funded Medicare, would pay what was deemed as allowable costs, as defined or covered by the policies. This was also a time of great expansion for healthcare, and the number of healthcare facilities increased dramatically. As this happened, healthcare organizations were focused on their financial needs, and in particular on capturing revenues. Prior to the 1960s, there were few computers in general use, and they were extremely large, unwieldy machines. Beginning in the 60s, the technology expanded from using punch cards to store data to using more advanced technology like magnetic disks. Computer terminals and real-time processing became the norm as the demand for access to computer-based programs began to rise. Back then, computers were physically very large machines that required lots of resources and were called mainframes, or sometimes big iron. These large computer systems supported multiple uses simultaneously, but the services they offered were almost entirely centralized. These centralized services were used primarily for functions such as accounting, billing, or what became known as number crunching. These large computers were very costly, so only very large organizations could afford them. There were also very few applications available to perform specific functions, so virtually all of the applications needed to be programmed or developed from the ground up if an organization wanted one. So how was this technology used in healthcare facilities in the 60s? The reality is that these large computer systems were mainly used for office administrative functions, such as accounting and billing. Because they were so very costly, they were almost exclusively used by large hospitals and academic medical centers. However, small organizations sometimes had the opportunity to share resources through a process called time sharing, where a large organization would grant computer access to a small organization for a fee based on how many computer resources the small organization wanted or needed. In this decade, healthcare professionals and healthcare organizations began to have conversations about what role computers might play in the clinical settings in the future. But in actuality, because of their size, cost, and complexity, computers were not really used in those settings yet. With the 1970s came the arrival of the minicomputer. The role of Medicare and Medicaid programs continued to expand, and the number of healthcare facilities increased in both numbers and size. This meant healthcare costs grew considerably, and cost containment became a driving issue. This was the decade when the minicomputers were first introduced. They were smaller and more affordable, so they could be used in many more places by more diverse organizations. But they essentially operated like smaller versions of mainframes, which meant that off-the-shelf applications were still very rare and operations were still essentially centralized. This decade also saw the dawn of computer networking, where these machines were beginning to be connected to one another which was a precursor to the Internet. At this time, systems were developed and made available for healthcare organizations to purchase. Nurses started to pay attention to information technology, and they realized that computers could in fact be used to improve areas such as documentation and patient safety. Shared systems were still being used, and there were systems designed during this time that eventually led to some of the major systems used in healthcare today. The 1980s were when informatics in healthcare really emerged, but let's look at what was happening in healthcare first. Previously, Medicare would make payments throughout the year, and then the hospitals would file a cost report at the end of the year, which would be reconciled based on allowable costs. The term for this is retrospective cost-based reimbursement. Payment would be based on actual costs during the previous year. However, in the beginning of the 80s, Congress mandated a change in order to try to control steadily rising healthcare costs. Under the new system, inpatient cases were divided into groups depending on the diagnosis and the expected level of care. It's called diagnosis-related groups, or DRGs. And each case would be paid a flat rate depending on which DRG was filed. In addition to controlling costs, this system was also meant to be an incentive to hospitals to become more efficient, as they would then be allowed to keep the delta between their costs and their revenues. Medicaid and other insurance companies soon followed suit. To this very day, DRGs continue to be the basis of how hospitals get reimbursed. On the technology front, computers in the 80s became even more compact. Personal computers, or PCs for short, were affordable, so even small organizations such as practicing physician groups could afford them. In addition, off-the-shelf software applications were now available, which freed organizations from having to develop their own programs. This meant a great increase in the use of information technology. It also meant decentralization, as employees would have their own computers. So we went from centralized computing with the computing power located in one or very few locations in the form of mainframes that were accessed via terminals, to distributed computing where the computing capability was spread out using PCs and mini-computers. This meant users were no longer shackled to the IT department, and they now had control over what and when they wanted to work on certain tasks. However, in order for these computers to share data and applications, they needed to talk to each other, and as a result, networking was reinvented. Local area networks, or LANs for short, were for buildings, departments, or small organizations, where users needed to share data or resources like expensive printers, or communicate with each other through a relatively new technology called email. Wide area networks, WANs, on the other hand, allowed various computers of all sizes, talking PCs, mini-computers, and mainframes, located at different sites, to talk to each other and share data. These networks were beginning to take advantage of the ultimate network, which became known as the Internet. Previously, organizations such as hospitals had looked at computers mainly as a way to decrease costs by having the computers perform certain functions, like billing more efficiently. However, the changes in information technology meant the use of clinical information systems grew considerably. In addition, we now had the ability to store increasing amounts of clinical and billing data and integrate this information into organizational structures known as databases. Affordable, powerful computers were now available to small organizations, allowing them to integrate financial and clinical information in an effort to become more profitable. For nurses, the clinical applications would simulate the old Cardiac system and allow them to chart vital signs, notes, etc., along with narrative nursing notes. Moving on to the 90s, the Clintons attempted to reform health care but met opposition and ultimately failed, while the cost of health care continued to rise both to consumers and the government. Medicare changed how physicians were reimbursed twice in this decade to try to contain costs. However, healthcare costs continue to grow. Well, think about what happened to our population at that same time. As a whole, the country grew older. The advances made in healthcare meant that people lived longer. We're able to treat infections, acute illnesses, and trauma much better. But with the longevity came along a long list of costly chronic diseases such as diabetes, cardiovascular diseases, renal failure, cancers, and COPD. In 1980, over 90% of the population who had health insurance were enrolled in unmanaged fee-for-service insurance, with the rest being in health managed organizations or HMOs. However, by 1996, this number was down to 25%. The rest of health insurances were divided into HMOs or preferred provider organizations, PPOs, all of which incorporated aspects of managed care. In other words, health insurance companies became increasingly involved in the management of health care. The decade ended by the Institute of Medicine publishing a report in 1999 that called for the creation and adoption of computerized medical records. We'll talk more about that in detail later on. Now back to the technology. In the 1990s, personal computing continued to gain steam. The cost of hardware dropped dramatically, and commercially available software or off-the-shelf software became widely available. This meant that there were so many more functions and programs available, and they became increasingly more user-friendly. However, this decade is probably more known for the advent of the World Wide Web. The original Internet was actually started back in the late 50s and early 60s by an agency called the Advanced Research Projects Agency, or ARPA for short, which was funded by the U.S. Department of Defense. ARPA created the first versions of the Internet to facilitate computer-to-computer communications between large universities and government sites, principally for researchers to share data and results. One significant drawback to this early version of what would later be called the Internet was that it was not a persistent network like we have today, and all of the computers that needed to participate in communication sessions needed to be brought online and physically connected to phone lines in order to talk to each other. In the 70s, specialized networking protocols were developed to help make it persistent, that is, the Internet, and it finally started taking off in the 80s, but it was not until the 90s that it became widely available outside of academia and the government. In the 1990s, the Funded Domain Name Registry was created, and a new layer was added to the Internet to make it easier to use and navigate. Thus, the World Wide Web was created. The Internet is a network of networks consisting of tens of thousands of connected computers called servers, yet there is no one overriding governing body. It is paid for and maintained by various organizations that have a vested financial interest in maintaining a point of presence or multiple points of presence, like Internet service providers, governments, universities, and commercial entities. The Internet is not a thing, a place, a single technology, or a mode of governance. It is an agreement, said John Cage, who is Director of Science for Sun Microsystems. So what does this mean for healthcare systems in the 90s? The Internet revolutionizes how organizations communicate with each other, how they market their services and conduct their business, and healthcare organizations take advantage of this. A multitude of healthcare information products and services are developed by many different vendors, and not just for the administrative functions such as accounting and billing. Clinical applications become more available and cost-effective, not to mention easier to use, and they're brought into the clinical settings such as operating rooms, patient units, and emergency rooms where they're used to help monitor, document, and manage patient care. Yet there's still a relatively small growth in the adoption of systems that use the computerized or the computer-based patient records or electronic medical records, EMRs, despite the fact that the Institute of Medicine names this a priority. The Institute of Medicine, or the IOM, is an independent, non-profit organization that works outside of government to provide unbiased expert advice to both decision makers and the public. The end of one millennium and the beginning of another was marked by two important reports published by the Institute of Medicine, To Err is Human, Building a Safer Health System, was published in 1999 and claimed that between 44,000 and 98,000 people die each year from preventable medical errors. Next came Crossing the Quality Chasm, a new health system for the 21st century, which was published in 2001 and exposed 6 specific areas where improvement was needed in our healthcare system, namely safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. Healthcare costs continue to grow at a rate much higher than inflation, and both consumers and the government demanded transparency. Consequently, there was a call for pay-for-performance, and healthcare information technology was seen as a key element in achieving this. However, even though there was a call for the implementation of the electronic medical or health records, this did not translate into large-scale implementation in the clinical practice. Why was this? Well, first off, there were no consistent standards in place. Data fields were given slightly different names by different organizations. Let's say a field containing the patient's first name is called first name by 2 different systems, but one uses a capital F and the other does not. As humans, we can easily decipher this information and figure out that this is a field containing the patient's first name. However, computers simply can't do that. Then think about all the different variables and different fields that are associated with the care of just one patient. And think about how one oncology patient may differ from, let's say, a maternity patient. Finally, add the need to protect the privacy of the people whose information is contained in these records, and you can see how this quickly becomes very, very complicated. Another key issue has been a lack of motivation, since having an EMR, or more precisely an EHR, that can be shared between different organizations does not always benefit the organization that creates the EHR in the first place. Next, having to learn how to navigate complex system interfaces can be daunting too, and quite frankly, most healthcare providers, such as nurses and physicians, did not choose the profession because they wanted to be tied to a computer for their entire shift. Rather, they're drawn to human interaction. Finally, add a lack of knowledge of the benefits, compounded by simple confusion about what exactly the EHR is. Given, as you've already learned, we have different terms for them, such as computerized personal record, the CPR, electronic medical record, the EMR, electronic health record, the EHR. All of these overlapping terms can definitely lead to confusion. The end of the decade was marked by the financial crisis of 2008 and a growing number of people without health insurance. This led to one of the most important pieces of legislation for health IT, namely the Health Information Technology for Economic and Clinical Health, or the HITECH Act of 2009. Which was part of the American Recovery and Reinvestment Act of 2009. It provided a $19 billion investment into transforming healthcare through the use of technology. The HITECH Act also provided the legislative mandate for the Office of the National Coordinator for Health Information Technology. This is a division under the Department of Health and Human Services that was initially created by executive order in 2004. Their purpose is to coordinate nationwide efforts to implement and standardize the use of health information technology and the electronic exchange of health information. Substantial funds were set aside and subsequently given to healthcare organizations who work together and adopt meaningful use of the EHR with the goal of ultimately improving safety and decreasing costs by avoiding duplicate tests or procedures and by improving the continuity of care for patients. So what was going on with information technology during this decade? The growth and rapid adoption of technologies leveraging the Internet literally tore down long-standing barriers to data, and information became available to everyone, including consumers. However, organizations struggled to pull meaningful information out of the glut of data that was now being collected. So a major focus of this decade became analytics, which embodies the ability to extract and analyze data so it becomes meaningful. This decade also saw a resurgence of big iron as mainframes, which never really went away despite rumors to the contrary, reestablished their prominence in domains focused on large-scale enterprise-wide applications such as enterprise resource planning and human resource information management, just to name a few. So what were nurses doing? A grassroots organization started by a group of nursing leaders formed the Technology Informatics Guiding Education Reform, also known as the TIGER Projects, and they held a summit in 2006. Out of the summit came action steps to help prepare the nursing profession to use technology and informatics with the goal of improving the delivery of patient care. The TIGER initiative, or the TIGER project, continues to be a driving force in implementing and changing nursing informatics. So what were nurses doing? A grassroots organization started by a group of nursing leaders formed the Technology Informatics Guiding Education Reform, also known as the TIGER Project, and held a summit in 2006. Out of the summit came action steps to help prepare the nursing profession to use technology and informatics with the goal of improving the delivery of patient care. The TIGER initiative continues to be a driving force in implementing and changing nursing informatics even today. So let's sum this up. While the EMR was slow to be adopted in the beginning of the 21st century, the use of the Internet by everyone grew immensely. Consumers gained access to healthcare information from Internet sources, some great, some not so great. Wireless technology entered the scene, and PDAs, also known as palm-top computers or personal data assistants, pagers, and cell phones became commonplace in healthcare. The end of the first decade in the 21st century saw the beginning of a large federally funded investment into healthcare IT. This takes us up to 2010 and beyond. The key words are healthcare reform, mobility, and virtualization. The Patient Protection and Affordable Care Act was enacted in 2010 with the goals of increasing the quality and affordability of health insurance, decreasing the number of uninsured through expansion of public and private insurance coverage, and reducing the cost of health care. It includes mandates, subsidies, and newly created insurance exchanges, and requires new minimum standards for health insurances, and prohibits the insurance companies from offering different rates based on pre-existing conditions or sex. There's been a large infusion of funding into the health information technology to increase its use, and over 50% of hospitals had adopted use of EMRs by the end of 2012. We've also seen a change in who is in the business of providing health care, with the emergence of convenient care clinics where patients can walk in and receive health care in grocery stores or drugstores, often staffed by nurse practitioners, but also sometimes by physicians. As with the previous decade, the Internet is front and center in the advances of information technologies, moving forward in two very specific ways. First is the advent of cloud computing, which aims to leverage the power inherent in the millions of computers connected to the Internet. The second is the incredible proliferation of smart devices, which give people greater and more persistent access to information resources and ultimately to each other than ever before in history. Cloud computing is all about leveraging the vast power base that exists in the world through devices that are attached to the Internet. There are three aspects to cloud computing that impact people and organizations alike, namely, access to applications running in the cloud, think Facebook or Google, access to storage, think Dropbox or iCloud, and finally, access to infrastructure, which is more targeted at institutional use and personal use, but impactful nonetheless. It may be argued that the advent of smart devices like smartphones and tablets is the singularly most impactful technology at a personal level in the history of information technology. In part, this is true because the proliferation of smart goes well beyond cell phones and portable computers. It has infiltrated our cars, our homes, and our bodies in the form of fitness bands and such. The smart devices have allowed us mobility, or the ability to access and transport information without being tethered by cables like never before. And it is one of the key reasons why social media has virtually exploded in our society and looks poised to dominate information technology for years to come. So where are we with the healthcare information systems at this time? Physicians can now use the computerized physician order entry, the CPOE, to replace handwritten orders. And we even have the e-prescribing taking the place of paper or faxed prescriptions. Telemedicine enables providers to reach patients who are unable to travel or live in hard-to-reach places. We use barcode scanning to verify patients' identity and for medication administration. Radio frequency identification, that's RFID chips, are placed on nurses and assistants to collect data on how much time they spend on different tasks. Much of the equipment we use in the healthcare setting is now equipped with microchips. This means the bed has a built-in alarm and ability to weigh the patient. Certain beds can even rotate slightly to prevent patients from acquiring bed sores. The machine we use to take the vital signs can wirelessly transmit the data so it can be merged with the EHR. We even have smart pumps that have a library with lists of medications built into it to prevent common errors. We've mobile workstations on wheels, WOWs, with a computer and barcode scanner and sometimes even a printer, all connected wirelessly to the internet. Tablets and smartphones are used by providers as well as patients. We're even seeing a move towards patients maintaining their own versions of an EMR, namely the personal health record, the PHR. This concludes this introductory presentation on the history and evolution of healthcare information systems and how computers, smart technology, the internet, and the World Wide Web are used in healthcare. Thank you for listening.